This program is brought to you by Emory University.
Okay, so my talk is double outlet right ventricle. And so basically we're just going to kind of get rid of the mythology and make sure that it's like more simple for double outlet right ventricle, because I think a lot of people get confused with this one. So the objectives are to discuss the nomenclature of double outlet right ventricle, review some imaging, and then discuss the importance of the VSD relationship to the great arteries, and then the types of repair. So most of the information I got was from Moss and Adams, which is essentially our book on pediatric cardiology that has like all the information in. And then I also like the surgical book from Marusis. So I probably said his name wrong. So this is what I think most people think when they think double outlet right ventricle. They see DOVR, okay, double outlet right ventricle. I will tell them it's a double outlet right ventricle. And then there's about a paragraph of diagnoses after that. And then you ignore it, and then you get confused, and you don't know why you signed up for this congenital rotation. And so then you just stop right there. But actually, it's probably more important to look at the stuff after the DOVR. Or DORV. So, because that actually tells you more about the patient's anatomy. The DORV basically is just telling you about the relationship of the VSD and the great arteries, as well as the continuity of the aortic and mitral valve. So this is what Dr. Maley and Bob Anderson said about double outlet right ventricle, is that it represents a spectrum of congenital malformed hearts, and that there is, it basically circumferences both the arterial valves, and the greater part of both of them are kind of supported by the right ventricle. And then there's a subclassification is based on the relationship of the VSD and the great arteries. Tells you more about what they act like. So that still kind of seems kind of vague, so you still might have some questions. But some background information on double outlet right ventricle is basically both of the great arteries, they need to have more than 50% arising from the RV. And then it accounts for only 1% of the congenital heart population, so it's a very small percent of the general population as a whole. Only 0.06 cases per 1,000 births. It was first described in 1893, and then I think at Johns Hopkins they first started to describing the Tausig-Bing heart, which they kind of called a partial transposition of the great arteries. And then Mayo finally used the term double outlet right ventricle in 1957. So, and it's a part of the conal truncal defects family. So those are tetralogy of Fallot, transposition of the great arteries, interrupted aortic arch. So it's kind of within that spectrum. So this is a question from Moss and Adams. So double outlet right ventricle is best defined by A, bilateral conus, malposed great arteries, aorta mitral continuity, greater than 50% commitment of both great arteries to the RV, and then conal truncal or contruncal VSD. So what do you guys think? Okay, D, good. So at least you guys remembered what I said. So basically, the two things that create a double outlet right ventricle for the terminology is you need greater than 50% commitment of both of the arteries to the right ventricle. And then second, you need to have discontinuity or kind of a lack of continuity between the mitral valve and the aortic valve. And we'll kind of go over what that means. But those are the two things that you need to have a double outlet right ventricle. So this is when they talk about aortic mitral continuity. You see, you have the mitral valve is right next to the aortic valve. There's just kind of a thin layer of tissue right there. There's nothing like thick. There's no big chunk of muscle at all. So unlike, this is kind of one of the features that you see for the left ventricle, is usually there's no like muscle tissue right here. It's just a nice thin wall. So. And usually we'll see this kind of in the parasternal long axis view. But with lack of continuity between the aortic and mitral valve, you basically see this big, thick chunk of muscle, and this is like conal tissue. So this is what you usually see surrounding the pulmonary valve. So this is mitral valve and aortic valve. And then on CT, you can kind of see it here. You just see that there's like a big chunk of muscle. Normally this conal septum is underneath the pulmonary valve, but in double outlet right ventricle, it's underneath both. And this is just a pathology specimen kind of showing that conal truncle, or the conal septum right there. So, and then the 50% override. So if you look at the VSD, so again, this is that same parasternal long axis view. If you look at the VSD, which is here, and you take this ventricular septum and draw a line straight over, if more than 50% of this aortic valve is into the RV, like across this line, then you would consider that more than 50% override. So you would need to see that big chunk of tissue here and then 50% override. That's all it means to be a double outlet right ventricle. It doesn't tell you the relationship of the great arteries. It doesn't tell you how they need to be repaired. It's just kind of talking about that. So there's a lot of other associated congenital heart disease that you will see with double outlet right ventricle. Most commonly it's pulmonary stenosis, and that can be kind of within the tetralogy form as well as within the transposition of the great arteries form. And it's up to about 50% of the cases will have some sort of pulmonary stenosis, and that can be valvar or kind of infundibular stenosis, kind of subvalvar stenosis. Just kind of within the whole conal truncal defects, there are about 10% of the patients will have some sort of coronary anomaly. So it's important to image that before, but also in the adult patients, kind of seeing where those coronary arteries come off if you're putting in a melody valve or something that may compress some of the coronaries. And so most commonly, about 25% of the cases you'll see will have a segundum ASD. And then the transposition type of double outlet right ventricle will have more arch anomalies as well. Okay. So in all of it, it's all about the VSD relationship with the great arteries, kind of tells you how these patients will actually be treated and how we manage them in adulthood. And then the importance in the adulthood is where that VSD relationship was, determined on what kind of surgeries they have, and then you just manage them how their original surgeries were. So this is kind of your normal, so there's usually no VSD at all when you're looking at the right ventricle here, so this little diagram. So this is pulmonary valve, and then this is the aorta usually kind of sits right here. And this is like a picture of a paramembranous VSD where the VSD is right here. With double outlet right ventricle, you'll start to see that aorta right here and kind of overriding into the RV. So you'll be able to see on echo, you'll see flow into the aorta from this. So with the tetralogy of flow type, it's basically a subaortic VSD. It's similar position as a paramembranous VSD, but it's just right below the aortic valve. And then you'll also have some pulmonary stenosis, or the pulmonary valve will be squished. So it will act physiologically like a tetralogy of flow. With the subpulmonic VSD, so basically it's right below the pulmonary valve, that is going to act more like transposition of the great arteries because it's easier for blood to flow out to the lungs. And then doubly committed is that it's just a big VSD that kind of overrides and it's close to both. And it really depends, we treat these really depending on how they act, but usually they'll act more like a large VSD. And then if it's a double outlet right ventricle, but it's just directly below the aortic valve, but no pulmonary stenosis, it acts more like a VSD. So, and the usual timing of surgery depends on kind of their type that they're like. So if they have the VSD type, it would be just a VSD repair in infancy, depending if they're starting to have failure, maybe it'll do it a little bit earlier on. If it's If they're a little bit older, kind of later in the first year of life, and they're starting to have pulmonary overcirculation, then you would repair it, usually if they're older or bigger than like 5 kilos. And then the tetralogy type, usually we would try to repair these now, if possible, before 6 months of age, so that they wouldn't have any sort of TET spells. And then the transposition type, usually we would repair these like similar to transposition of the great arteries at this point within the first 7 days of life, before the left ventricle becomes unprepared. And then the non-committed type is basically the VSD is very remote and more in the muscular septum. And so we kind of want to see what that VSD, like if it starts to become very small, because it will change the repair. And the repair is a little bit harder because the baffle is a little bit longer. So let's talk about it. Oh, it's black in this one. Okay. This is weird. Okay. So the VSD type is basically a subaortic VSD without pulmonary stenosis. Like I said before, it essentially acts like a VSD. There's a left to right shunt, so blood is shunting from the left ventricle through the VSD to the aorta, and then the pulmonary, you will get pulmonary overcirculation. This is about 15% of the double outlet right ventricles. And then the only real thing that you would notice is that the aorta is overriding more than 50% into the left ventricle, or to the right ventricle, and then also there'll be a loss of the aortic mitral continuity. And the great arteries will be normally related. Okay. And so basically this is kind of a picture from the surgical book that just kind of shows them doing a patch repair. So they're just going to go through the right atrium and then just unroof that VSD and then just put a patch over it. So, and then the tetralogy type, basically it's a VSD with pulmonary stenosis. So physiologically it's acting like tetralogy of Fallot. And so you have VSD, PS, and overriding aorta. And you'll also get the right ventricular hypertrophy that you would see in other forms of TET. So again, the blood is going to flow from the LV to the VSD and then to the aorta. And you'll see the differences on the echo from a normal tetralogy of flow is you'll lose that aortic mitral continuity. This is the most common type of double outlet right ventricle in about 40% of the patients. You'll also, similar to tetralogy of flow, you'll see that same dynamic component for that infundibular or the subvalvar component of the pulmonary stenosis, and then more of a fixed component of the obstruction at the level of the valve. So they're at risk of TET spells, and then they may be cyanotic if it is severe pulmonary stenosis. So this is on echo, which you can kind of see. So here, you still see that the aorta is here, mitral valve's here, and then you see that big chunk of tissue here. And then the aorta is overriding, and if you draw a line across, it's more than 50%. This is just looking at kind of inflow-outflow view of the right ventricle. Pediatrics, we flip all of our images so that we kind of look at it the other way. So when I started, I had to relearn echo because you guys keep everything upside down. And so this is the right ventricle here. This is liver here. You can see that when they add the color flow Doppler, you can see color going to the aorta as well as the pulmonary artery. So thinking more of a double outlet right ventricle. And then you can also see that it's a little bit of turbulent flow here for the pulmonary stenosis. So, and because you've already defined that this is the aorta here from some of the other imaging that they don't show, that you know that this is a subaortic type of VSD, and then with pulmonary stenosis because some of these views. The parasternal short axis view is also a good one to look at as well. So these patients would be repaired very similar to patients with tetralogy of Fallot. So sometimes if their anatomy they would need surgery early in their anatomy because of coronary arteries, or they don't think that they can physically do it on the size of the baby, they may kind of palliate him for some time with a modified BT shunt or kind of a central shunt to get more blood flow to the pulmonary arteries. But they will also sometimes do a transannular patch, which is kind of depicting here, where they cut across that narrow pulmonary valve, resect out that infundibular, that conal tissue that's obstructing the subvalvular area for the pulmonary artery, and then they'll kind of patch close the VSD. So afterwards, you would follow them very similar to Tetralogy, a Fallot patient. So this patient with a transannular patch is going to have the same pulmonary insufficiency and the same risk long-term about getting RV dilatation and needing a pulmonary valve in their early 20s and 30s. So you're still going to follow them the same way. And then you will also might see kind of that VSD patch closure and then an RV to PA conduit if they needed it. If they get an RV to PA conduit, as we talked about in some of the earlier lectures, they will need more surgeries kind of going forward because they're going to outgrow that RV to PA conduit. So, and then this is just, I think it's easier to start with a picture with the transition type. So this is an RV angiogram, and you can see contrast going both to the aortic valve as well as the pulmonary valve. And then this is another injection in the LV, and you can see the VSD here. And then you can see that the VSD relationship, it's a lot closer to the pulmonary artery compared to the aorta, which is way over here. So you can see that the blood would flow a lot easier from the LV across the VSD to the pulmonary artery and kind of give you that transposition of the great arteries or complete transposition of the great arteries type of physiology. So the transposition type has like a lot of names to it. So you could call it double outlet right ventricle with subpulmonic VSD, or you could say double outlet right ventricle with malposition of the great arteries, or essentially transposition of the great arteries, or you could call it a Tausig Bing heart. So in pediatric cardiology, we haven't always decided on an easy way to call things. We like to have 4 names if it's like somewhat confusing. So that's what we did. But it's essentially, this is a transposition of the great artery with a VSD. So, and it's going to be repaired as such. So in this case, because the pulmonary valve is closer to that VSD, there's going to be a lack of the pulmonary and mitral continuity. So you're going to see that thick chunk of tissue. So, and then the blood is going to flow from LV to through the VSD to the pulmonary artery. And this is the second most common type of cases of the double outlet right ventricle. And the physiology, they're going to basically be very cyanotic at birth, kind of depending on the size of the atrial communication. If the atrial communication is restrictive, they probably need a Rashkin. So to kind of open that up. So, and this is the one that's most associated with the hypoplasia of the aortic arch or interruption of the aortic arch. So, and as we talked about in the double outlet right ventricle, or the transposition of the great arteries talk, so whenever you see 2 of the great arteries kind of in parallel in the parasternal long axis view, you have to be suspicious for some form of transposition. So exactly the same. So you're going to see pulmonary and aorta here. And so again, these are the subcostal views, so they're upside down for you guys. So this would be the VSD. The CS here that they're pointing to is just like conal tissue, so the conal septum, so that thick area of tissue. And then blood is a lot easier to flow through the VSD to the pulmonary artery here. And so this is just showing kind of the teen procedure. They didn't show in this drawing the Lecomte because they didn't bring the pulmonary artery forward, but you can just see how they basically switched the pulmonary artery and then the aorta, but kind of left the roots there, and then just ended up taking the buttons of the coronary arteries and moving them. So, and then closing the VSD to kind of that old pulmonary route. This is just showing a picture of a transposition of the great arteries, kind of an arterial switch, but also with reconstruction of the aortic arch here. So you can see the aortic arch is hypoplastic, and then there's a coart there, and then you have the pulmonary artery, and then the PDA here, so you can kind of see all their suture lines. So the only real difference between that and the one before is that you've kind of reconstructed that whole arch. And then this is the LeCompte, because the pulmonary arteries are kind of draping across the aorta. So, and then you potentially could do the Rastelli, which is that complicated patch that takes the from the VSD and kind of tunnels it all the way through the right ventricle to the aorta. And then most of the time they will get kind of an RV to PA conduit with this. So, and with this, if the VSD here is too small, and you started off with something too small or got smaller as the patient grew, you're essentially going to have subaortic stenosis. So, and then this is just an echo picture of like a doubly committed. So this is the VSD here, and then aorta and pulmonary artery. This is in a subcostal view. You just see that it's easy for the blood to flow both ways. So I don't know why this one is black. This is the second one that's weird. But this one is supposed to show the uncommitted, and essentially it's like a muscular VSD that's very far away, and this is less than 10% of the cases, and it's very distant. So, and potentially they may need a pulmonary artery band or a shunt, kind of depending on the flow. So, and so this is your question to see if you guys actually paid attention to what I just talked about. So the type of double outlet right ventricle associated with a higher pulmonary artery saturation before repair would be a Tausig Bing, VSD, Tetralogy of flow, non-committed, or doubly committed. So why is that, George? Because you're right.
That's the one that behaves almost like a DTGA, so that you have LV that's going through the pressure going through the pulmonic valve, and oxygenated blood going through the pulmonary arteries with the water circulation.
Okay. So, and these are all the things that we look at when we make the decision on how they get repaired, is the size, the number of VSDs, and the relationship to the conduction system. Also kind of the distance between the tricuspid valve and the pulmonary valve. So if you have any sort of the AV valve chordae or anything crossing that VSD, it's going to be a lot more complicated of a repair, and you may not be able to do a 2-ventricle repair, just depending on the relationships. And then also, like we talked about through most of the lecture, just the relationship of the great arteries, whether or not they're normally related or if they're demalposition of the great arteries, if there is any sort of pulmonary stenosis, if there is any stenosis of the left ventricle outflow tract, and then the coronary artery anatomy. So, and this was from, I like this picture, it's a little blurry, but it's from Moss and Adams, and essentially it just kind of takes you down what we discussed before they get sent to repair. There are some of the double outlet right ventricles that I didn't discuss that can be kind of a form of heterotaxy that will go down the single ventricle pathway as well. Or if you can't create a baffle, you cannot close that VSD safely because of chordal tissue from the tricuspid or mitral valves, then you might have to go down the single ventricle pathway as well. So, and then the complications that we see in adults are essentially whatever type they were, then you just kind of follow it as it. So somebody with a subaortic VSD, so like essentially a VSD without pulmonary stenosis, they would be like a repaired VSD, so they don't have as many complications as if they would long term. So, and then for the right ventricle outflow tract obstruction and PI, so which of the types would you think we'd have to follow that for? Yep. And then the let's see, what about coronary artery stenosis? I always wrote it in there, arterial switch. And then which one would you watch a little bit more for the arrhythmias, especially the ventricular arrhythmias, if their Q restoration was greater than 180? What type? Good. Okay. So, thank you.
The preceding program is copyrighted by Emory University.